Morning, everybody. It's nice to be here. Um, I got some feelers of some stuff that happened yesterday. We could not participate online, and that's marginalization. So for those of us who were online, President Abudozo and the LOC, please consider that has to be sorted. Anyway, well done. I'm glad we're all having a memorable time at Abuja. And as I said on the first day that we had some lectures, that I'm really excited that the Abuja experiment is working out. Well done, everybody. So this morning, I'll be discussing reporting ultrasound findings in obstetrics. My name is Ibrahim Awowale from the Obafemi Awolowo University, Ile-Ife. And as I always say, when it comes to writing ultrasound reports, you could have generated very fantastic images, very accurate planes, painstakingly done all your measurements. But if you don't do a proper report, it's like presenting a wrapped gift that was never unwrapped, or wincing in the dark when nobody can see you. And of course, you have to make sure that your report is something that the clinicians can use. Okay? Sometimes as obstetricians, we get away with not writing properly constructed reports because we're the ones to do the scan. We know what we saw, and we know how we're going to use that to manage the patient. However, in a lot of situations, you have to write that report for somebody else who was not there at the time you were doing the scan to use. And remember, unlike cross-sectional images, where you have the radiology films or the CT or the MRI sections, ultrasound scan is often real time. So you have to be able to describe appropriately whatever you have seen while scanning that patient. The first thing I need to remind us of is that ultrasound reports are written in present tense, not past tense, okay? So do not write something like the fetus was alive. No, you need to write in present tense. A live fetus is seen in longitudinal line, And remember that there are standard parameters that you need to document. We will look into that. When you write ultrasound report, please write in simple tenses. Avoid excessive technical descriptions that makes it difficult for anybody to understand your report. And this there is a good example of what I'm talking about. So you have the doctor on one side, and you have the patient on the other side. And as you can see, both of them are confused. The doctor looks confused. Now let's go to the report itself. The first thing you need to note is that you need to have at least 2 identifiers on every report that you write. So don't just write Atiku Oluwaseun and you expect that that patient is the only Atiku Oluwaseun in the world. There must be a second identifier. It could be the patient's date of birth, it could be the hospital number, but there must be a second identifier apart from the patient's name on your report. Again, remember to write the name of the healthcare provider, name of the ultrasound facilities, and your report should carry a contact information. This is standard, okay? Because sometimes the clinician may see your reports or somebody else, and they may want to seek further clarification or provide additional information for you. If there is no way to reach you, then it becomes impossible to optimize the care of that patient. When you scan anybody, please remember to provide relevant clinical information on your reports, okay? Especially the indication for the examination. Many of us overlook this or see it as a waste of time, but I want you to, after this training period, take time to look at professional reports. You will see, it's always there, indication for the procedure, and every relevant clinical information will be there because you need that to be able to interpret appropriately, okay? All ultrasound reports must be dated, and you must say which examination you have performed. If it was a transabdominal scan, say so. If it was transvaginal scan, or if you are doing a combination of both. I am quite deep into managing women with risk of preterm birth. And so I end up doing a lot of transabdominal and transvaginal scans together in pregnancy. And you see, I will always write it there. The patient has had combination of transabdominal scan and transvaginal scan. Okay, so you need to write that as well. You see, all this preliminary information, please do not see it as a waste of time. It is very essential that you have them on your reports. Sometimes we have systems in place, and as part of that system, somebody may be scanning and another person may be writing the reports. Okay? But please note that it is the person that scans that takes responsibility for the accuracy of the report, not the person that typed it. All right? The person that typed it is not responsible for that report. It is the person that scanned the patient. So you take responsibility for the report. And as such, once a report is ready, before you sign it, please make sure you read it again and make sure that you personally sign reports. Okay? And it is important. Sometimes we have a very busy clinic and you may end up scanning 2-3 patients and you then come back later to write reports for them. Unfortunately, as I have said, ultrasonography is real time. So you may not have that benefit of absolutely perfect recall anymore. It is always better to write a patient's report as soon as you finish scanning that patient. Don't scan 3 patients consecutively and then sit down and start writing. You may miss something very vital, such as placental location or presentation. And if there is a condition that requires urgent attention, please remember to communicate this directly to the appropriate personnel once you scan the patient. We will see an example as we move along in this report. If you have encountered limitations that compromise the quality of your examination, such as high body mass index, please report this and write there that you encountered a technical difficulty. This will help the clinicians in how they interpret your results. And please know that you don't need to write expected date of delivery every time you scan a patient. The first thing you must clarify is whether a reliable EDD has been established for this patient. Sometimes you may even be the one that has scanned the patient 2 or 3 times earlier. And every time you scan that patient, you keep writing EDD, 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 and you realize that you have scanned the patient 3 times and you have written 3 different EDDs for the same patient in the same pregnancy. That is not acceptable. Once there has been an established EDD for that patient, please write that as part of the preliminary data information that you write at the beginning of your report. Agreed EDD, and put it there. It does not change. And I'm sure we will all remember that the earlier you scan a patient, the less the margin of error. So the earliest EDD done by a proficient personnel is usually the most reliable. And so when you scan patients, sometimes you ask the patient, when is your EDD? The woman will ask you, which one? Is it the one they gave me when I did the first scan, or the one they gave me when I did, or the last one you gave me? Because every time we scan these patients, we write new EDDs for them. But please note that once a patient has an established EDD, please don't change it when you write your own reports. It is perfectly acceptable and professional not to include EDD in your report. In the early part, write agreed EDD and put it there for the patient. So let's move on to goals of doing your scan. You need to confirm pregnancy viability and confirm the location of the pregnancy. I'm sure we should all by now have been using the term panoramic view. Well, if you want to be decent, we say panoramic view, but in my experience with taking the practical sessions of this course, all I hear trainees say over the years is panoramic, panoramic. So we just say panoramic. And that's a fantastic concept that everybody must remember. You need to remember that you need to have that panoramic view so that you can see how many fetuses are there, what is the location. It is failure to do this that make people miss things like abdominal pregnancy, because they just assume that once you see the pregnancy there in the midline, it's in the uterus. It may not always be. So remember the location, things like interstitial, intramural pregnancies. If you do your panoramic view, you will not miss them. Okay? Determine gestational age and growth. If you have the capacity, detect fetal anomalies. I think we'll be doing more of this next week. Remember to assess amniotic fluid, placenta, the cervix, and the adnexia. And of course, always check for multiple pregnancies. In fact, as part of my scanning practice, before I scan a patient, I often ask them how many babies are there. And this has saved me on one location where there was a previously dead fetus, which had now become very small. I had finished scanning the woman, one fetus growing normally. I asked the woman at some point, how many babies are here? Just my routine. And the woman said, they said that two. I said, oh, two? And by the time I checked, there was a second one there that was almost reabsorbed, dead, just by one corner. So I was able to eventually write a report and say there is also a second fetus, demise of one twin. So please always remember to do that. We will have some additional discussions about multiple pregnancies soon. Relationship of the placenta to the internal cervical os should be documented. This is the most important thing about placenta. Sometimes we write whether it is anterior or posterior, which is fine. At other times, we write the grading of the placenta, which is also okay. But please note that those ones do not directly impact on the clinical management of the patient. The most important information about the placenta is the location of this placenta to the internal cervical os. And I'm sure we will have discussed that the cutoff is 20 millimeters. If the distance between the lower edge of the placenta and the internal os is less than 20 millimeters, then consider that the patient has a low-lying placenta. And you can take this position from the 16th week of gestation. All right? From 16 weeks, you can write that. And if you see low-lying placenta at any point in time, as part of the recommendations, when you finish your report, write there that that patient needs to have a repeat scan at about 34 weeks to localize the placenta. Okay, remember the cord, the number of vessels in the cord, Multiple gestations will require documentation of additional information. We'll talk about that in a minute. Now, storage. There should be a permanent record of the ultrasound examination and interpretation in the facility. In Nigeria, we don't have an absolute law about this. But please note that abroad, these records have to be stored for 21 years. And so you see that trust diagnostic facilities have invested heavily in storage facilities, electronic storage in the cloud. They store all relevant images, they store the information, because if anything happens to anybody, a lot of tracings can be done, and some of them may be traced to the care the woman received in pregnancy and in labor as part of investigations. Somebody may be interested in why he did not get a first class, and they are trying to see whether it was because the doctors have missed something. Take that literally, but the important thing here is to know that you must have record. Some of us may type or handwrite report for patients. Please store all relevant images and store records of the patient's reports. Okay. Now let's look at first trimester scan. When you are going to report this, please remember to report the location of the gestational sac and the number of gestational sacs. Okay. Always remember, if it is intrauterine, you must say so. I have seen reports that says things like a gestational sac is visualized measuring. No, that's not sufficient. Where is the sac? Is it in the endometrial cavity? Is it intrauterine? Okay, we must state it in early gestation. And you can measure the size of the gestational sac if there is no visible fetal node. If a fetal node is visible, then report the size of the fetus, not the gestational sac anymore. You only measure gestational sac, report gestational sac if you cannot see the fetus. And in cases where you cannot see the fetus, but you can see a yolk sac, then reporting the presence of the yolk sac can be quite reassuring. You can report the yolk sac is present and whether it is regular or not. You see like a donut inside the gestational sac. This is a very important and reassuring finding when you see it in early gestation. Crown rump length is the standard measurement for the embryo, and this is what you should report when you are dating the pregnancy up to gestational age of 13 weeks and 6 days. Okay, up to 13 plus 6, please use CRL, up to CRL of 84 millimeters. You use crown rump length. Remember to document fetal cardiac activity for all your scans. Even if it is not there, you must write that it is not there yet and decide when you want to see the patient again. If it is there, then write that it is there. So whether it is present or absent, you must put it there. And as I've said earlier, crown rump length supersedes any other measurements in first trimester when you are dating a pregnancy. Okay, so if it is early gestation, don't use gestational sac to date as long as the fetus is visible. Measure the fetal crown rump length and use that. Okay. There are situations where you will see, you can see a gestational sac, but you cannot see the fetus yet. In such instances on your report, and I see this a lot of times, please do not write an EDD, okay? Or if you do not visualize cardiac activity, these things I'm saying are just things that some of us might not have taken note of. I'll give you an example. I saw a scan where somebody said a fetus is seen in utero, CRL measures equivalence of 12-week gestation. There is no cardiac activity. Okay. EDD, so dates, assessments, missed abortion. So if you have seen a fetus that does not have cardiac activity, then why are you writing EDD on that scan? So this is a technical issue that I want us to all take note of, please. So when you are making a diagnosis of missed abortion, please, I know you will have measured CRL to date that fetus, but don't put EDD. And when all you could still see is a gestational sac or a fetus without cardiac activity, please don't put EDD at that time. Rather, this patient needs to do a scan in 10 days or 14 days, as the case may be, so that you see a fetus, you see cardiac activity, and then you can then add EDD to that report. So we don't need to add EDD to that of a fetus that has no cardiac activity. If you move on from 14 weeks, what we do is to write the composite, composite biometry in monitoring growth and dating the pregnancy. Okay, and the composite biometry, commonly the 4 parameters: biparietal diameter, head circumference, abdominal circumference, and femur length. And I'm very sure that we have had a lot of teachings about the landmarks to use for this. Your reports does not require you to write the landmarks. You only need to write the measurements and the centile, or for those that write gestational age, it is fine. You don't need to write whether you saw the ventricles or whether you saw the intrahepatic portion of portal vein. Your report only requires that you write the name of the parameter, the measurement in millimeters, and the clinical correlates with respect to the centile. As part of your 6-step sweep, you remember that the first step is presentation. So please remember to write that. And all your documentations should include estimated fetal weight at all times. Now, stemming from coming to this program, the other thing I want to challenge you to remember to do is to write the growth centile. A lot of the machines already have incorporated centile estimators in their software. So once it gives the estimated fetal weight, it tells you which centile that fetus falls. So you see a report that says estimated fetal weight is 1073 grams, in bracket 54th centile for gestational age. That makes your report professional, all right? And that shows that you have had training in report writing for obstetric scans. So when the clinicians are trying to compare growth centile for a fetus that the mother has had scans 8 weeks ago, 4 weeks ago, today, it's very easy. They can then look and say 8 weeks ago, the fetus was in the 50th centile. 4 weeks ago, the fetus was in the 30th centile. Today, that fetus is in the 10th centile. This growth has slowed down remarkably over time. And that decision becomes very easy and relevant because you have made that job easy for everybody by including growth centile in brackets of estimated fetal weight. If you have not noticed it, when you go back to your centers, you will see that the ultrasound machine will put the centile beside the estimated fetal weight. Okay, and as you go on for your scans today, please look out for it on your machines as well. Most likely you will see the centiles there. And if you have been writing reports for patients before now and you are not adding it, when you write today and tomorrow, please remember to add growth centile to the estimated fetal weight. It's very important. Okay. Amniotic fluid, you can write amniotic fluid index or you can write deepest vertical pool. Both of them are comparable in terms of clinical utilization. In fact, evidence shows that the deepest vertical pool is faster to do without losing clinical information. So you can choose either of the two that you want to write, but please remember to comment on whether it is normal or abnormal. Multiple pregnancies. This is where many of us falter. There's a difference between writing a professional report and writing report by scope. Just know that I'm able to do a scan, so I can write the report the way I perceived it. You may not always be right, okay? So please, I want us to pay attention to this as well. And by the way, by the time I finish, there is a short exercise at the end of this discussion that I will expect everybody to participate in. We're going to critique a report that will be pasted on the screen. So please be ready to do that exercise. So when you scan multiple pregnancies, you have to do what we call fetal mapping. And in fetal mapping aims to describe each fetus, okay, so well that, because for you to be able to do a growth chart for each fetus, you must consistently assign the same label to each of the fetuses. So, otherwise, when you plot, you will see growth charts that are scalloping, and that's not right. That may suggest that the fault you are seeing on the chart may suggest that you have mislabeled one of them, or you are plotting one against the other. So when you start scanning multiple gestation, do a panoramic view, check, and as you are doing that, you will start to record the relevant information about each fetus. That's what you use to map when you write your report. So describe it as many characteristics as possible. So your report will go something like fetus 1 or twin A or twin 1 is to maternal left. Usually, twin 1 is the one that is aborting on the cervix, because the cervix is a landmark that does not change. So that may still help you further. And in terms of vaginal delivery, that's the one that is likely to come out first. So if you say your twin A or twin 1 is to maternal left, okay, what is there? Lie, longitudinal lie, cephalic presentation, cardiac activity is present, the placenta is anterior, it is male, okay? Now you go to twin 2 or twin B. Twin B is above and transverse to maternal right. The placenta is posterior. It has demonstrable cardiac activity. Twin B is female. These are the preambles that you have to write before you start to write about head circumference, biparental diameter. First, you have to map those fetuses. If they are triplets, you do it for each of them. Twin C is in the middle. It is a breech presentation. Twin C is female. Twin C, I hope we are getting it. This is how you will write your report. And anybody that picks that report and sees how you have mapped those fetuses understands perfectly what you are saying, and that this person has written a comprehensive and professional report. Next, you will move to chorionicity and amnionicity. This again is very critical, okay, because it determines how frequently that pregnancy will be scanned. If it's monochorionic or dichorionic, for example, okay, you have to state it. If you're able to see the lambda sign, write it there. That lambda sign is visualized, and usually you do this before 14 weeks. Okay, if you are not able to see the lambda sign, the next most reliable is the fetal gender. Okay, if they are of two separate genders, that is confirmatory for you that they are certainly dichorionic there. Okay. Amnionicity, you must state whether a dividing membrane is present or absent when you write the report. In my clinical practice, this is where I sometimes have challenges, and I never stop to teach our resident doctors and trainees. Over the years, a patient will bring ultrasound reports. there is no statement about the presence or absence of a dividing membrane. This has to be clearly documented, because if the dividing membrane is absent, that may mean we're dealing with a monoamniotic pregnancy. And you know that for a monoamniotic pregnancy, the minimum chance of perinatal mortality is 40%. Okay? So we have to start to watch out when we do our scans for cord entanglement and all those challenges. So I asked my resident, you saw this report, they did not write about dividing membranes. What did you do? You could have sent the patient back or bring the patient into our own unit and let us scan and assess the presence of dividing membranes. If the dividing membrane is absent, it's a very serious situation, because it means we're dealing with a monoamniotic twin. And if further assessment is required, then make the arrangement for that. Now, individual biometric data for each fetus. You must record biparental diameter twin 1, twin 2, head circumference twin 1, twin 2. But before you will be able to do this, there is a condition that you must fulfill. And I say this because I've passed through every stage of learning in ultrasonography. When I started scanning, and I was scanning twin fetuses, the machine would just do an automatic averaging. If I take head circumference twin 1, head circumference twin 2, the machine will add the two together and find an average. That's what the machines always do. Unless you have told the machine that you are scanning more than one fetus. Okay? So if you click on the biodata page on your machines, you will see there is a place there that asks for number of fetuses. If it is twins, then write 2. If it is 3, triplets, then write 3. That way, when you finish measuring twin 1 and you go to twin 2, you can tell the machine, I'm now in twin 2. When you move to twin 3, then you tell the machine to switch to twin 3, and all measurements will be recorded under twin 3. By the time you finish scanning and you press report, the machine will display for you twin 1, twin 2, or triplet 1, triplet 2, triplet 3. But you will only get this, as I said, if you have already selected the number of fetuses. Otherwise, the number of fetuses is set at 1. And that means as you move from one fetus to the other, the machine will continue to sum and add them. But when you write your report, please remember that you are supposed to write the biometric parameters for each fetus separately. The next important thing when you write for twins, amniotic fluid. Please remember, amniotic fluid should be written differently. And unlike when you write report for singleton pregnancies that I said you can use DVP or amniotic fluid index, in multiple gestations, you can only use deepest vertical pool. And I see results and I smile that will report AFI for twin 1, AFI for twin 2. It's nearly impossible to be doing amniotic fluid index in multifetal pregnancies. So please remember that we only write deepest vertical pool. And when you do your lectures, they will tell you the precautions that you have to take. Now we're just discussing reports, okay? So when you write report for multifetal pregnancies, you only write deepest vertical pool. You don't write amniotic fluid index. All reports must carry a statement about discordance. Discordance is reported in percentage. And once you have entered into the machine that you are scanning twins, the machine will calculate discordance for you automatically. The issue is whether you know that it is there and whether you know that you are supposed to write it, okay? So discordance must be written because this helps the clinician to assess for any problem, whether selective growth restriction or twin-to-twin transfusion syndrome or whatever. And if your machine does not do it for you, I have put the formula to calculate discordance there. Estimated fetal weight of big fetus minus estimated fetal weight of small fetus divided by estimated fetal weight of big fetus times 100%. That gives you the discordance. EDD, yes, this is one thing that you must also know. Again, I always smile when I see the reports that many of us write as professional colleagues. When you scan twin gestation, by the time you look at the ultrasound reports, okay, the reports will give you EDD for each fetus. And often what I see is somebody will write triplet 1, EDD, 1st of January, triplet 2, EDD, 10th of January, triplet 3, EDD, 7th of January. That's not true. That's not right. It's the same pregnancy, okay? So the consensus globally is that when you scan multifetal pregnancy, you will only write one EDD. And that one EDD you will write is that of the larger or the largest fetus, as the situation may require, okay? So you will only report one EDD. So if you look at the examples I have given there now, one of the fetuses has EDD of 1st of October 2025. The second fetus has EDD of 7th of October 2025. So, my esteemed colleagues, can we unmute? Can somebody answer? Which EDD should we write for this fetus? Is it 1st of October or 7th of October for this pregnancy? What will be the EDD, or should we write the two? What's the correct answer? 1st of October, 7th of October, 1st and 7th written together. Which one?
1st of October. First. About 4 people have responded.
October. Fantastic. Thank you very much. Excellent. And I hope everybody got it right. Okay, so please, these are things that you need to know when you write your reports, okay? Excellent. So it does not matter how many fetuses are there.
Yeah,
don't write 2 EDDs, 3 or 4 EDDs on one report. What did you say, sir?
Which one is the answer?
They all got the answer. Oh, okay, fantastic. The answer is 1st of October. That's the answer. Okay. So you use the earliest EDD because that is the larger swing. 1st of October. That's what you write there. All right, let's move on now. Common pitfalls. Missing key measurements. Okay. Overusage of vague terms. Probably, maybe, you have to be careful when you use terms like that, because remember that the clinician will be using our reports, or sometimes we know what we're saying, but the person that will be reading that report afterwards has no clue as to what you saw. So be careful of using woolly descriptions like this. The fetus may be alive. No, don't write that, okay? So please, let's be as certain as possible. Special scenarios like fetal anomalies, intrauterine growth restrictions, non-reassuring Doppler studies, these should come in under their specific topics. So I did not discuss them here in particular, unless there are demands for that maybe later. Trends. It's very important to write about trends. Okay, if there is any fetal part that you have seen that is abnormal, you must write. All right. Don't just write something like the heart is enlarged or the lateral ventricle is enlarged. No, you must write the measurements so that when somebody else scans another time, or even if you are the one scanning, you'll be able to say, this was what it was the last time, this is what it is today. And that way we can follow the trend. If it's a pair structure, you must compare with the other side. The right ventricle measures this, the left ventricle measures this, so that we know whether this problem is unilateral or bilateral. Make recommendations for follow-up studies and give the appropriate time to do so. Okay, so if you want the patient to do that in 2 weeks or in 4 weeks, it is completely fine to put it in your reports. Okay, and again, see who is supposed to see the patient. I have given examples here. Because I combine my clinics, I scan and I also do the clinical obstetric practice. It is often easier for me to bring specialists to my clinics. And because we have established a multidisciplinary team for fetal medicine in my hospital, usually the most senior person in the unit will either come or delegate somebody who will come and then feed them back. I don't know if this is what happens in your hospital, but in my hospital about 10 years ago, if you call maybe pediatrics or pediatric surgery that we have a pregnant woman that has a scan of a fetus with a problem, they will say, call us when the baby is delivered or when the woman is in labor. Was that the experience in your centers? In my center, that was the experience. But now it's no longer so because we have reached a significant level of understanding. So when the report comes and we confirm and we call pediatric surgery or neonatology or whoever we're calling, we will meet the woman while she's still pregnant together. We will discuss everything while the woman is still pregnant. Some of them will say, okay, I want to bring my husband next visit. We will meet with them again. Some of them will visit neonatal ward or visit pediatric surgery ward before their babies are born. So that when the babies are born, the surprise factor is already taken away. So I put that in my report as well. And I'll say, I will arrange a meeting when this patient comes with so person in 2 weeks' time. And that can be in your report when you do that. In order to avoid missing relevant information, you can use proformas, okay? And I am sure that we have all seen this ISO proforma. When you do anatomy scan, you will also use this to report the anatomy scan, all right? The essence of proformas and checklist is not for you to cram, so that when you now finish, then you just quickly tick everything. No, it is for you to look at while you are doing your scanning and be sure you have not missed anything, okay? Because if you don't use it as your guide while you are scanning to say, is there anything on this list that I have not done? You may fall into the error of the checklist phenomenon, okay? And on the checklist phenomenon, what happens? You just tick, 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 tick. Let me give you an example. If you scan regularly, you realize that 97 to 98% of the fetuses you scan will be cephalic presentations. And so almost always you have a template that says the fetus is in cephalic presentation. The day you see breach, you may still end up writing it as cephalic presentation because you're already used to it. Or you may say placenta is not low-lying. The day you see a low-lying placenta, you may mistakenly write it as not low-lying. That's the checklist tick box phenomenon, because that is what you always get. So when you use checklist, please be careful of that. Okay, so here we are now ready for the assignments. I want all of us to take 2 minutes to read this report, which will have been a standard report for any of us, perhaps, before this lecture. And at the end of 2 minutes, please, let's get the microphone ready. Let's unmute. And the speaker should probably come close to the device so that I can hear, or we take the microphones to them. What do you think will be done better in these reports? What could be done better? We have 1 minute remaining. All right, so thank you very much. I have learned a lot from everything you have said, and I'm going to take everything into consideration, and I'm going to write a new report, okay? So now let's look at my new report based on the polite bashings that my report has received this morning. So after your comments, this is my new report. Let's look at it together again now. And you will see that I have now dated the scan, right? We have put hospital number. Look at the history. Reduced perception of fetal movement in the type 2 diabetic patient. And by the time you look at the fetal heart rate, 98 beats per minute, that changes everything. Because we now know that this type 2 diabetic patient who has complained of reduced perception of fetal movement, the fetus in fact has fetal bradycardia. Okay? So you see, transabdominal scan was done. Somebody spoke, just the last person I spoke to said, I did not state the limitation. High BMI, that's probably why I could not see the placenta clearly. The BMI of the patient was high. Lateral ventricles are now measured right and left, okay? And now I am saying that this patient needs to have an urgent review because the fetal heart rate was 98 beats per minute and is persistently low. Somebody else said that I'm supposed to write a follow-up plan. Yes, now I have done that. And I have informed the consultant, Dr. Nabudozo is going to manage this patient for us. So thank you. Yes. And we now know that Cornelius Broadhead is not a painter or a bricklayer. He is in fact a senior registrar 1 in radiology department. We now know that now. I'm glad somebody else also brought that up. So you see, these things, if you look at this scan and the previous scans, the measurements are the same. BPD is the same, head circumference is the same, AC, FL, measurements are the same. So they both got the same thing. However, look at all the extra information that this person has now put after attending the lectures this morning. This is the way I want us to think. Never, ever see it as a waste of time writing a comprehensive, detailed, and professional report. Ladies and gentlemen, the only thing left here is to thank you for listening to this lecture, and I will take questions if you have any. Okay?